In this chapter, we'll discuss the urinary system. Early on, we discussed the cavities of the body, and we discussed the abdominal pelvic cavity and the lining of it, which is called the peritoneal membrane. The lining on the wall in particular is called the parietal peritoneal membrane, or the parietal peritoneum. So remember, the kidneys are actually what they refer to as being retroperitoneal, meaning they are actually outside the peritoneal cavity. And just as an FYI, the left side is slightly higher than the right side. There's a little bit of a shift of the entire human body when you consider that the left lung only has 2 lobes as opposed to the right lung having 3. Then the left kidney is a little higher, and the testicles in the developing fetus are going to be just posterior, just distal to the kidneys. And just an FYI, you'll actually see that when a male baby is born as cryptorchid, in other words, one testicle does not descend into the scrotum from the abdomen, it's almost always on that left side. Just some regions that you should be familiar with. First off, just about every organ, such as brain, bone, etc., we talk about the medulla and the cortex. So the medulla is going to be this entire interior region here, and then the cortex would be this section right out here. So the renal cortex versus the medulla. So you'll have the ureter, which is the tube coming into the kidney. It expands into the renal pelvis. The pelvis is then going to divide up into the major and minor calyces. So you've got pelvis, you've got your major calyx, divides up into the minor calyx. So these minor calyces are down here. The other things to look at would be the renal pyramids. They're referred to as pyramids because they're rather triangular in appearance. And then between the renal pyramids, you'll have the renal columns. The renal papilla will be the little apex point of the various pyramids. I'm trying to get my stylus to cooperate with me here. Let me see, the only thing else on here, note there is a thick capsule on the outside, very tough, the capsule, that is made out of connective tissue. And then overall, when we look at the external anatomy, you'll actually see that the kidney is rather a bean-shaped organ, and this indentation area is known as the hilum, the renal hilum, and that's going to be where the ureter and the renal arteries and veins will enter the kidneys. So here is a fresh specimen, and you're able to see on this sagittal section of a kidney they've done, you'll see here you've got the cortex, then you've got the medullary area in here, and you get the impressions here. It's kind of hard to see because of the coloration, but of the calyces. And here, for example, would be some of the renal pyramids. The kidneys are fairly expensive for your body to run. They're going to require about 1/5 of the cardiac output, even though they're not structurally very large organs. They're about the size of your fist. They're very, very vascular, which would make sense when you think about the fact that they are actually acting as filters for your bloodstream. The functional unit of the kidney is known as the nephron, and you have over 1.25 million per kidney. So some things that you'll need to know, and we typically draw these out more simplistically so they're easier to follow. But the first thing is a renal corpuscle is going to be this entire section right here. So you can divide this out as a renal corpuscle, and you'll see that it's going to contain 2 things, the glomerulus and Bowman's capsule. The glomerulus is this cluster of capillaries in the center, and then Bowman's capsule is going to be surrounding it. So kind of picture a circular structure, like a little ball that's surrounding a clump of capillaries, about 50 little capillaries hidden away in there. So then as you leave Bowman's capsule, you'll go into the proximal convoluted tubule. They call it this convoluted, just meaning twisted. So you've got all these little spirals here. So it's proximal because it's closest to Bowman's capsule. So leaving Bowman's capsule, you'll be going down the descending limb, and then you'll be going through the loop of Henle, and then you're coming up the ascending limb, and then you go into another section known as the distal convoluted tubule, and from there you'll be going into the collecting duct, which will be heading down to the renal papilla. The renal papilla dumps into the calyces, which will dump into the renal pelvis, which will eventually leave through the ureter and to the bladder, and then it'll be voided out through the urethra. So I have all that written. What they've done in this photograph is removed all the kidney tissue that's not blood vessels. So you get an idea of the number of capillaries and the extent of the vascularity of the kidney. And then in this close-up view, what you're looking at in this lower right, that is actually a glomerulus. Again, you see it's simply a cluster of capillaries. Here's another look at the renal corpuscle. Again, the renal corpuscle will be this entire structure right here, and that's divided up into Bowman's capsule right here, and then the glomerulus in the center, so your cluster of capillaries here. You'll find that you have an afferent capillary going in and an efferent capillary coming out. So on the schematic to the right, again, here is your Bowman's capsule surrounding the glomerulus. Here is your afferent arteriole of the glomerulus, and there is your efferent arteriole. So Bowman's capsule would be leading into the proximal convoluted tubule. What stays in Bowman's capsule, what filters out from the glomerulus and stays in this tubular system, is going to eventually be excreted as urine. What is in this glomerulus is blood, and is going to be filtered out. It's going to have some exchange going on with the peritubular capillaries, and then this will be going into the renal vein and into the vena cava. Glomerular epithelium is going to be composed of these very thin, flat, irregular cells known as simple squamous epithelium. So you're going to have a couple of different layers. We talked about parietal versus visceral when we had early chapters talking about serous membranes. You have a parietal layer, which is going to be the same thing as the capsular epithelium. It's lining Bowman's capsule. The capsular layer really does not have any function in the filtration of urine. The layer that does function in formation of filtrate and eventually urine is going to be the visceral layer, and that is going to be overlying the glomerulus itself. So taking a look at this diagram on your left, again your capsular epithelium would be lining Bowman's capsule right here, and then your visceral epithelium is going to be what's on top of the glomerulus itself. And it just so happens this is going to be composed of a specialized type of cell known as a podocyte. Podocyte, the word itself means foot cell, and that has to do with these little extensions we'll talk about right here. Here is another diagram. Again, here is the direction of your proximal convoluted tubule. So this will be heading out, eventually getting to the loop of Henle and the collecting duct. On the other side, we're looking at the arterioles that are going into the glomerulus and coming out of the glomerulus. And again, you're going to have the parietal layer, the capsular layer, if you will, of epithelium, and then you'll see these podocytes. There's a nucleus of a couple right there, and that's the visceral layer of Bowman's capsule epithelium, and those are the podocytes. These little foot processes, these little extensions you see, are known as a pedicel. There's a word right there. So looking at this diagram on your right again, here is your nucleus of a podocyte. So this entire cell right there, the yellow, would be a podocyte. This would be a second podocyte right there. And these little extensions are pedicels, or foot processes. And they have the job of holding back larger molecules and letting these water and small molecules basically weep through there. So that's how fluid is filtered out of the bloodstream and into the capsular space. The gaps between the pedicels is referred to as a filtration slit. There are two types of nephrons. About 15% of them are known as juxtamedullary nephrons. These nephrons, again, what we're talking about is the structure right here, will have loops of Henle that go all the way down deep into the medulla. So cortical nephrons, they just don't extend that far from the cortex. So this is your cortex region, and this is the deeper part of the kidney in the medulla. That's easier to see on this diagram. Here on the right side, you'll actually see your juxtamedullary nephron. The juxta means near, and so that's why they refer to these as juxtamedullary nephrons. So the shorter nephrons, they don't go as deep into the medulla. Those are referred to as strictly cortical nephrons, and again, those make up about 85% of the total population. So this is going to be the papilla of your renal pyramid, and there you see the collecting duct entering that. This would be going into the calyx. The word vas erectus simply means straight vessel, and these are going to be the long straight capillaries that are going to be paralleling the loop of Henle, and these are going to be active in a process known as countercurrent multiplication that's going to help the concentration of urine. And in the middle of that, you'll see all these peritubular capillaries. Let's take a look at a group of structures known as the juxtaglomerular complex. Now, yes, this does begin with the word juxta too, meaning near, but don't confuse this with the juxtamedullary nephron we spoke about earlier. This is a juxtaglomerular complex. Sometimes you'll see it referred to as the juxtaglomerular apparatus, so the JGA or JGC. So juxta just means it's going to be near the glomerulus, and it's a complex of structures that are going to control the rate of filtration that's happening from the glomerulus and therefore control the blood pressure. Part of this JGC is the macula densa, which is actually a part of the distal convoluted tubule. Another portion of the JGA is going to be the juxtaglomerular cells, and we'll talk about those more in just a moment. And then there's also a group of cells known as the mesangial cells, and these are going to be smooth muscle cells that wrap around the afferent arteriole and control the diameter. As you can imagine, if those smooth muscle cells contract and constrict, they're going to close or reduce the size of the lumen of the afferent arteriole, which is going to reduce the amount of blood going into the glomerulus, which is going to reduce the amount of filtrate being produced, which is going to therefore reduce the amount of urine being produced. There's actually another type of mesangial cell that has a phagocytic type action, and these cells also help flush out the slits and remove aggregated groups of cell debris and protein that may have accumulated. The job of the macula densa is going to be detecting the level of sodium ions that is coming through the distal tubule. If sodium levels seem to be low, then the macula densa will signal the juxtaglomerular cells to secrete an enzyme known as renin. The enzyme renin will start an axis of hormonal activation, and so renin is going to cleave the hormone angiotensin, which is actually going to be converted into angiotensin 1, which is then also converted into angiotensin 2, and that is performed by an enzyme that is known as angiotensin converting enzyme. So every now and then you'll hear blood pressure medication advertised on TV, and in the little rapid talk at the end, they'll say this is an ACE inhibitor. So you can see if you take an ACE inhibitor, you're going to stop the activation of angiotensin and therefore blocking the effect of renin. So that would actually block the ability of the body to increase blood pressure. So I put a little scenario on here about renal artery stenosis. The term stenosis means to narrow a circular structure, as like constricting down. And so there are cases of renal artery stenosis that will cause high blood pressure. The way this happens is the renal artery, when it narrows, it's going to reduce the amount of blood flow that's getting to the kidneys. And so the kidneys are going to think that that your whole body is having low blood pressure, even though it's just to the kidneys. That's going to trigger the production of renin, or release of renin. That's going to activate the angiotensin system, and that also triggers another hormone to be released, a mineralocorticoid, from the adrenal cortex known as aldosterone. And all of these things are going to be sodium savers, and that's going to cause you to retain more water, which is going to increase blood pressure. So on this diagram, what you're looking at, to get oriented here, here is your PCT. So this is going to be going to the loop of Henle, the rest of the nephron. So of course you've got Bowman's capsule. You've got the whole glomerulus, which is right here. And then the juxtaglomerular apparatus is going to be consisting of these cells, the macula densa being pointed out right there. You've got the juxtaglomerular cells, which have the job of storing and secreting the renin. And then you've got the mesangial cells, which are the ones that you see demarcated by all this gray. And they're the ones that it will constrict to decrease the diameter of these glomerular capillaries and therefore decrease glomerular filtration rate. So this is just a schematic showing the summary of the activity of renin. Again, renin is going to be released by the juxtaglomerular cells of the JGC, and it's going to act on a molecule that's made in the liver, angiotensinogen, and it's going to convert it into angiotensin 1. And then the ACE, angiotensin converting enzyme, is going to convert that into angiotensin 2, which is going to cause vasoconstriction of the systemic blood vessels and also stimulate aldosterone secretion, which is going to stimulate sodium resorption and water resorption. So all of these things will activate the body's systems to increase blood pressure. Another hormone to remember that is produced in the liver is going to be erythropoietin. This was discussed in the blood chapter because it's going to be the hormone that's going to stimulate production of red blood cells by the bone marrow and long bones. Anything that causes the body to sense lower oxygen levels in the blood, let's say you've moved to the Swiss Alps, or let's say that you've got a respiratory disorder that's a long ongoing issue, you're hypoxic for some reason, or let's say that you're doing some activity that really needs prolonged levels of higher levels of oxygen. And so the kidney is going to sense that need and it's going to release erythropoietin. And that's going to in turn stimulate red blood cell production by the bone marrow. So let's take a look at the production of urine. And there are 3 stages, and we'll talk about these one at a time: filtration, reabsorption, and secretion. So if you recall, we've talked about blood colloid osmotic pressure and hydrostatic pressure several times. And what this equation is standing for is net hydrostatic pressure minus blood colloid osmotic pressure will give you the net filtration pressure. So the filtration pressure that's pushing or pulling fluid into Bowman's capsule is going to be dependent on hydrostatic pressure, which is the blood pressure, and then the osmotic pressure that's produced primarily by the plasma proteins. You can break the formation of urine down into several steps. So let's review our structure here. We're going to draw the afferent and efferent arteriole entering and leaving the glomerulus. Then we're going to draw our Bowman's capsule. From there we're going to draw the proximal convoluted tubule. We leave the proximal convoluted tubule and we'll enter the descending limb of the loop of Henle. And you have thick portions and thin portions of that. Not that I'm very decent at drawing it here. Leave the ascending loop of Henle, will go into the distal convoluted tubule, and then from there you'll go into the collecting duct, which will end up going to the papilla, which will empty into the minor calyx. So remember what's happening here is you've got blood pressure that's basically making hydrostatic pressure, it is hydrostatic pressure I should say, and that's pushing fluid from the capillaries into Bowman's space. So this is a process that's referred to as filtration. And from there, you're moving into the proximal convoluted tubule, and you've created filtrate in Bowman's capsule. It'll be moving through the proximal convoluted tubule, and from this space, you're going to have the substances that your body wants to keep being resorbed. So resorption happens primarily at the proximal convoluted tubule. You'll see that sometimes talked about being less important in some references. However, one of the things you do have here is microvilli. And anytime you have microvilli, then one of the main jobs of those cells will be absorption. So the filtrate will continue to move into the loop of Henle. And what happens here is going to be primarily the concentration of the fluid inside the nephron. So this is going to be happening in the juxtamedullary nephron. You're going to have vasa recta, blood vessels, that are going to be entering the process of the countercurrent multiplication, and we'll be talking a little bit more about that in just a few minutes. But the filtrate is then going into the proximal convoluted tubule, and from this point, what's happening is you're going to have secretion occurring where the body is getting rid of some things that it wants to get rid of. Certain drugs, certain toxins. You'll have medications such as antibiotics and anesthetics that are going to be metabolized through the kidney, and this is the point at which those will be secreted or excreted. So by now, basically, you've got pretty much urine. It can be tweaked a little bit depending on the action of antidiuretic hormone on some little pumps that we have over in this region. But this is your secretion. So that's a really rough looking overview of the next three steps we'll be talking about individually. So remember the definition of the renal corpuscle was a combination of Bowman's capsule surrounding the glomerulus. And this is going to be the site of the first step of urine formation. And again, that is known as filtration. That is a force that's going to be produced by the blood pressure, the hydrostatic pressure. And that's going to be pushing the water and small ions across the glomerular membrane. So these glomerular capillaries won't release larger molecules such as proteins because they're going to be too large to fit between the pedicels or the foot processes of the podocytes that make up the visceral glomerular epithelium. The reabsorption is going to be happening by osmosis, and again, that's happening in the proximal convoluted tubules. And be sure to remember that that's going to be where you find microvilli. So you actually are going to be producing about 180 liters of filtrate per day. If you had to urinate that out, you'd be peeing all day long. So fortunately for us, as long as your kidneys are properly functioning, you're going to reabsorb about 90% of that. And it's going to bring with it what your body wants to keep. So when you're reabsorbing something out of the PCT, is going into the interstitial fluid and being returned into the cells and capillaries there. This chart is going to give you an example of some of the things that's being reabsorbed here. So again, you've got your renal corpuscle right here, moving into the proximal convoluted tubule. You will see sugars, glucose, ions, water, and amino acids can be reabsorbed. They're going to be leaving the filtrate and returning into the body. So from there, we'll be moving down into the loop of Henle, and you will see the osmotic gradient. So here is basically 400 milliosmoles going all the way down to 1200 as you go deeper into the medulla. Again, this is representing a juxtamedullary nephron. So again, in this loop of Henle, you're going to have concentration occurring. Then you'll be going into the distal convoluted tubule, and from there you'll see what the water can reabsorb. And this is pretty much on an as-needed basis, water, calcium ions, sodium chloride, and you will have some variance here according if you're under the influence of things like ADH. What this chart was made by was to show you basically where certain types of diuretics work. For example, you'll have Lasix or furosemide that works in the area of the loop of Henle, whereas the thiazides are going to work in the DCT in collecting area. The countercurrent multiplication is sometimes simply referred to more broadly as a countercurrent mechanism. but it's simply referred to because you've got substances moving in opposite directions. So if you watch a video of the loop of Henle and then also look at the vasa recta as they cross it, you'll actually see a filtrate moving in this direction, and then you'll see blood flow moving in that direction. And what's happening is you've got things being exchanged between these two structures. So the big takeaway from this is what's happening is you're going to be concentrating the massive amount of fluid that you filtered out of the body. So one of the ways that you can try to remember this is that water follows salt. Your body needs to be able to retain water, but it can't because water can simply pass so easily across cell membranes. Think about if you were trying to catch water in your hands, it would simply run through your fingers. So in this case, if you're trying to manipulate water, the body simply manipulates salt, and water follows salt. Salt across the membranes. So that way, for example, think about if you've ever had too many margaritas or too many potato chips, and then you may have felt bloated that day, you've increased your sodium consumption, and so therefore you've temporarily retained more water. So that's how the body manipulates water reabsorption and also water loss. There's three big reasons that this countercurrent exchange mechanism is able to work. Number one, remember we talked about the shape of the kidney, and we talked about the renal cortex and then the renal medulla being the center area. Well, the deeper in the medulla you go, the more hyperosmotic you get. So basically, it's going to act like a sponge. And what creates this hyperosmolarity is going to be sodium and the urea. So the center of the renal medulla is very, very salty. And that allows that creation of that osmotic gradient that's so important. This is only going to be working in the loops of Henle of the juxtamedullary nephrons. So the cortical nephrons are not going to be responsible for very much of the concentration ability of the kidneys. So the other thing that's going to make this possible will be the sodium pumps that are going to be in the thick portion of the ascending limb of the loop of Henle. And they're able to push sodium out, and of course that's going to draw water with it. So that's going to, again, help the body further concentrate urine. So the third and final phase of urine production is secretion, and this is going to be things your body wants to get rid of, and it's going to be putting it into the tubules to be excreted. So there are no villi here. There's very little absorption that happens here. You're simply going to have things that are reabsorbed as needed. You've got water, calcium, sodium, potassium, and again, it's things like bicarb, and that's going to be regulated as needed in order to buffer the blood system. Nothing is absolute when we talk about generalities here. So again, just for testing purposes, go along with what I say on the PowerPoints. So for example, again, looking at your regions, you've got your Bowman's capsule, you've got your proximal convoluted tubule, and you see a list of things that are being reabsorbed into the body, but there's also going to be a few things here that can be excreted into the PCT. So again, nothing's absolute. Then you're moving into the loop of Henle for the concentration process. Again, you can see that urea is helping make up the osmolarity down here. You've got some things that can be reabsorbed here, especially sodium. And then in your distal convoluted tubule, mostly you've got things that are being secreted into the DCT, but again, you can have some things that will actually be absorbed or excreted as needed. And by that time, we've reached the collecting tubular collecting duct. It doesn't really matter which one you want to call it. Be sure you can understand the flow and formation of urine. So again, this is starting at the top. You've got fluid moving from the glomerulus into Bowman's capsule. That will move into the PCT. It's going to be concentrated in the loop of Henle. It's going to move through the distal convoluted tubule. It's going to join with other, the products of other nephrons in the collecting tubules, your collecting ducts. Those will be dumped out into the papilla, which is the little mound region at the end of the renal pyramid. It's going to dump out into the minor calyces, which will dump out into the major calyces, which will empty into the renal pelvis. That will go into the ureter, and that will be stored for a while in the bladder, and then go through the urethra for the process of voiding the bladder. The definition of the GFR, glomerular filtration rate, is simply the amount of filtrate that the kidneys are capable of producing in a minute. So if you look at this, this is simply the fluid that's being pumped from the capillaries via the hydrostatic pressure. It's not directly the amount that's going to be measured in urine. As I mentioned earlier, you can actually filter out 180 liters per day, so that's a huge volume. Fortunately for us, we're going to resorb 90% of that and the PCT. But it's helpful to know the GFR as a measure of how well are the kidneys working. And one of the ways I'll do that is to inject you with something and then measure how fast it clears from your body. The more traditional medicine they used to do that with was simply creatinine. And now they use something as a sugar known as inulin. And so they will inject you with that and again see how fast it's cleared through the glomeruli. And that gives them a number known as the GFR. The GFR is going to be determined on how much blood is coming in that afferent arteriole. So if you look at the hydrostatic pressure that's forcing the fluid out, that's going to be countered by the osmotic pressure that's going to be pulling fluid back in. So if you look at this formula right here, you'll see that basically the net filtration pressure is obtained by subtracting the blood colloid osmotic pressure from the hydrostatic pressure. So to make it easier, you could combine those two things and you could say that net hydrostatic pressure minus the blood colloid osmotic pressure is going to give you the net filtration pressure. So I wouldn't bother memorizing this list. It's probably easier to learn what shouldn't be in urine rather than what is. But of course, you look at ammonia, and we will talk about that in just a second as far as it being an important buffer. But you produce ammonia in your body every day from the proteins that you eat. And ammonia itself is very toxic. So this is the way it's going to be eliminated. So some of that's going to be also converted into urea. And then we're going to have uric acid that's going to be produced when you metabolize nucleic acids. Of course, you're eating that. Anytime you eat something that has DNA or RNA. Then creatinine or creatine will be from breaking down muscle tissue, either yours or someone else's. Then, of course, you've got all these other products of your diet: sulfate, phosphate, chloride, mag, calcium, and potassium. So urine. So here's what we talked about on the previous slide again. These are going to be waste products from organic material that we've consumed. So you see, again, urea, creatinine or creatine, uric acid, and urea is essential in maintaining that hyperosmotic renal medulla. When you do a urinalysis, you're simply looking at the properties of urine itself to try to derive some information about urine function. So this chart is a little bit fluorescent. The only time you're going to see colors like this would be if somebody's taking massive doses of B vitamins, especially B12. But you get the impression here. So as long as you're up into the lighter colors, that means that you're drinking an adequate amount of water. If you're getting down here in the darker side of that, then obviously you need to increase your water consumption. You're going to be looking at color, clarity, and odor of a urine sample. It should be, again, sort of a pale yellow. It should be clear. It should not be murky. It should not be turbid. And it should not have an excessively strong odor, although that can be affected by certain foods. The other thing that can affect the odor is if you have a really high protein diet, then you'll have more of an ammonia smell. So I always tell my students that one of the things that the doctors used to do in earlier days before they had a lot of advanced techniques of testing urine is they would actually do a taste test. And that way they could actually discover who had diabetes mellitus because their urine would actually be sweet. So I guess you could always tell the urologist because they would have bad breath. So in lab, we do a dipstick procedure that will give you a sort of a rough screening. It's not going to be a precise test, but it will give you an idea of things like white blood cell, leukocyte counts, red blood cell counts, um, nitrates, glucose, specific gravity, those sort of things that will give you an idea if maybe you're dealing with anything like diabetes or a urinary tract infection. It will also give you a pH scale to look at. Urine is normally going to be fairly acid. So the specific gravity is best measured by an instrument known as a urinometer. So specific gravity is basically comparing the concentration of your urine to your plasma. If it is the same as your plasma, it's referred to as being isothenuric. If it's more dilute than your plasma specific gravity, then you're referred to being hypostenuric, so your urine is being diluted by your kidneys, and so you know at least your kidneys are doing something. And then if your kidneys are working fully, your urine will be concentrated. So if you have a urine sample and the specific gravity is isothenuric, you simply don't know if the kidneys are functioning or not. You'll have to do another sample a little bit later to see if it's actually cooperating then. So in the old days, they would actually do a water deprivation test to see if the urine got more concentrated then. But of course, if somebody's in fulminant renal failure, you do a water deprivation test, you're probably going to kill them. We've talked about pH briefly, and you know that buffer is going to be referring to something that's going to neutralize a strong acid or a strong base. And a strong acid, for example, is going to be signified by hydrogen ions. If you add that with ammonia, for example, which would be NH3, that's going to go into NH4. So what you've done, you've tied up hydrogen ion. Phosphate is going to work the same way. It will go from H2PO3 to H4PO3. And again, this is simply tying up the hydrogen ions so they can be excreted to regulate the pH. The other function that the kidneys can play in maintaining pH is they can increase the amount of bicarb that's taken back into the plasma from the tubules. I wanted to mention here what happens when you reach the renal threshold. So there are several substances in the bloodstream that your body will push into Bowman's capsule, but you reabsorb that, so your body's going to keep it. But you're using carrier proteins to bring that back into the body. And if you have a whole lot of something in your bloodstream, you can actually overwhelm those carrier proteins. The best example I've heard is, let's say that you've got 100 boats and you've got to bring 100 people from the other side of the river. And so as long as you've got enough boats for that amount of people, you're not going to have any leftovers and everybody can get back home. However, if you've now got 120 people on the other side of the river, you can still only bring 120, so you're going to have 20 people left over. So I don't know if that helps or not, but let's say that you've got diabetes mellitus and your blood sugar is 562. So you've got so much blood glucose that you're going to have a lot of that, so that's going to be pushed into Bowman's capsule, and it's so much that your body can't reabsorb it all at the proximal convoluted tubule. So the excess, those other 20 people on the other shore, is going to be spilled out into the urine. So the term that you use is say that your transport maximum has been reached. And at that point, you've reached a renal threshold and you'll end up with glucosuria. Just wanted to give you a group of definitions here. Kalemia refers to potassium. So hyperkalemia is excessive serum potassium. Hypokalemia is when you don't have enough serum potassium. So we'll talk about that more in the chapter about metabolism. These cases can be deadly. Hyperkalemia can actually lead to heart attacks, and hypokalemia can lead to extreme weakness and coma. So pH, we've talked about a little bit before. That's going to be talking about the level of hydrogen ions that are going to be in your body. And respiratory acidosis is actually the most common, followed by metabolic acidosis. Alkalosis is when your pH is too high, and that's a little bit less common. So your kidneys are one of the two major buffer systems in your body. The bigger, faster one will be the lungs. The kidneys will be the smaller, a little bit slower system to control your pH. So the word diuresis is basically used now to talk about production of a large amount of urine, and a diuretic would be a medication that will induce that. So in other words, if you want to produce more urine, you will take a diuretic. Micturition is simply voiding your bladder. It's the act of peeing, basically. And these next two words I give you simply to introduce you to the term pyelo, because it's referring to the renal pelvis. So a pyelogram is when you are injected with a dye, usually iodine-based dye, and then your kidneys will be x-rayed so you can see the outline of the renal pelvis. And one of the reasons you'll do that will be looking for something that blocks that renal pelvis, such as a kidney stone or potentially a tumor. And then pyelonephritis, there's a itis, so you know that's inflammation. So pyelonephritis will be simply an infection or inflammation of the kidney, including the renal pelvis. Glomerulonephritis is when you've got something that actually involves the glomerulus. Sometimes this can actually be an immune-mediated reaction. So because you're actually causing a lot of damage to those tiny little capillary tufts. And in this case, you can expect to see a lot of leakage of protein into the urine. And then finally, cystitis, cyst referring to the bladder. So a very common condition. It can simply be caused from ascending fecal bacteria going up the urethra. The urethra in females is much shorter and wider, and so women are much more prone to bladder infections than men are. And women are very prone to cystitis after a sexual intercourse. That's one of the reasons that if you are prone to bladder infections, your gynecologist will tell you to make sure that you get up and go pee after having sex. Now let's move from the kidney into the ureter. These are going to be smooth muscle tubes that will be lined with transitional epithelium, and they use peristalsis to push urine from the kidney down toward the bladder. You can actually see on ultrasound what they refer to as jets of urine being propelled into the bladder via the ureters. Don't confuse the ureters with the single urethra that exits the bladder. The bladder itself, just like the stomach, has the grooves and ridges known as ruga, and that allows the stretchability, expansibility, and the normal bladder can stretch to hold about 1 liter of urine. The trigone of the bladder is a triangle that's formed by the entrance of the ureters. They kind of wrap around the back, and they enter right there, and then the urethra. So you've got this triangular area that is known as the trigone of the bladder. So the detrusor muscle is 3 layers of smooth muscle that make up the wall, and then notice this is representing the visceral epithelium. There are 2 sphincters, just like you saw in the digestive system. You have internal and external, so you've got smooth muscle and skeletal muscle, involuntary and voluntary. The female urethra, as I mentioned before, is short and wide, whereas the male urethra is narrow and long. So women suffer a lot from cystitis. Men suffer more from kidney stones because it's much more difficult to pass one. So another thing that men get to deal with is the prostate, and here you see the position of the prostate around the urethra, and most men as they age will develop BPH, or benign prostatic hyperplasia, and that can impinge on the ability to produce a normal forceful stream of urine. As I mentioned earlier, in the ureters and the bladder, you will find transitional epithelium, and this is the only place you're going to find it is in the urinary tract. And what's special about it is when the bladder is empty, you see these nice big fluffy cells that look rather columnar in stature, And then when the bladder is full, they're going to stretch out into more of a squamous type formation. So this allows the bladder to go from a very small structure, not too much bigger than a plum, to something that can hold a liter or more. Just wanted to mention a few things here. The detrusor muscle, when you urinate, is called the detrusor reflex. This is going to be involuntary. You're not aware of the urine that's accumulating in your bladder until it's going to be large enough of volume to trigger your stretch receptors. At that point, your brain is notified that, hey, you really need to go pee. So the detrusor muscle reflex is going to weaken with age, so it gets a little bit more difficult as you age to fully empty your bladder. And just a little tidbit of information here, the sensitivity to the urge to pee gets reduced at night, so that way you're not going to be peeing as much at night as you do during the day. It just helps you sleep a little bit better. So the external urethral sphincter is the only skeletal muscle involved here, and again, that's going to give you some voluntary control. And the ability to release that is going to be controlled by a center in the pons, so in the brainstem. So urination process itself is fairly complicated. You're going to be inhibiting some muscles, you'll be stimulating some muscles, and also there's other things that go into this as far as things like your prefrontal cortex saying, okay, this is socially appropriate to urinate now, and also some involuntary things, even known as posturing. So there's certain postures that are recognizable. If you see someone urinating, a man by the side of the car passing on the highway, for example, you can automatically know when he's peeing out the off the side because you can tell by the way he's standing. So that's sort of an involuntary automatic reflex. So don't get too bogged down on this. I just wanted to show you this is a fairly complicated procedure here. The overall process of urination is a parasympathetic procedure, so you've got to be relaxed. Some people have what they call a nervous bladder, and in other words, they won't be able to pee in front of somebody or even sometimes in a public restroom. So you can have things, what they refer to as an upper motor neuron bladder, if you have a brain or spinal cord injury, and that means that you can't relax the sphincters, or you can have a lower motor neuron bladder, which might be like what you would see in multiple sclerosis in advanced cases where you have urinary incontinence. So again, you've got to be constricting the bladder for your detrusor reflex, and you've got to be relaxing the sphincter. So you have to be inhibiting these muscles while stimulating these. When you talk about central control of urination, you're talking about the nervous system, and you're also talking about the endocrine system. So as we've mentioned before, the parasympathetic system is going to stimulate the ability to urinate. However, the sympathetic system also has some input, mainly by being able to constrict the afferent arteriole to reduce the glomerular filtration rate and therefore reduce urinary output. So the hormonal controls that you have will be the hormones ADH, angiotensin, and aldosterone. Antidiuretic hormone is going to implant little aquaporins into the distal convoluted tubule in the collecting duct, which allows water to be resorbed much faster back into the body. So it's going to decrease the amount of urine that's actually produced. So hence the name antidiuretic. So by using those aquaporins, you're increasing the permeability of those tubules. Angiotensin, remember that is going to be triggered by renin release, the enzyme renin. Angiotensin is a sodium saver, and so it's going to make you retain sodium, which make you retain water. It also is going to, as a side effect, cause vasoconstriction, and that's going to increase blood pressure. Angiotensin also triggers the release of aldosterone from the adrenal cortex. Aldosterone is a mineralocorticoid that is a sodium saver, so it too is going to decrease the output. The only thing that's a sodium loser will be the natriuretic peptides. Atrial natriuretic peptide and brain natriuretic peptide. Those are both produced by the muscle of the right atrium of the heart. And their release is triggered when that right atrium is stretched by larger than normal blood volumes. So if you look at the term natriuretic. Remember, natrium is Latin for sodium, and so uretic is urination. So natriuretic means you're going to be urinating out sodium. So those are sodium losers, and those will cause you to produce more urine. So you can think of these things as far as increasing the amount of water you're going to be saving. So these will be decreasing urinary output, and then the natriuretic peptides will increase urinary output. The Pontine Nutrition Center is, as it sounds, in the pons, so it's going to be on that rostral brainstem, and it's going to be coordinating information from ascending sensory signals up the spinal cord with information from the insular cortex, the hypothalamus, even from the prefrontal cortex, and basically allowing the process of urination to occur. Because this is a long pathway, it's easily damaged. If you have severe spinal damage, I mentioned earlier the upper motor neuron bladder, you're not going to be able to relax the urethral sphincters, and you're going to have to be catheterized to be able to express urine. So again, the smooth muscle of the detressor muscle, that's going to be an involuntary reflex, but it's going to be overpowered most of the time by the prefrontal cortex, which is going to tell you when it's socially acceptable to urinate. So somebody who has a stroke in this area might not have the social prompting, so they might have inappropriate urination. And you could also end up with nocturnuresis, also known as nighttime bedwetting. You'll see that happening in normal children, especially little boys. That is something they typically will outgrow. Thought I'd mention kidney stones because you may have dealt with them or know someone who had. The term nephrolithiasis, nephro for kidney, litho for stone, iasis for condition. Sometimes you'll see the term renal calculus. So this can be brought on by genetics. You may be predisposed to developing kidney stones. They can be brought on by diet. They've now shown that the calcium supplements that doctors have pushed women to take all these decades or will now set you up for kidney stones. So the other thing, the biggest contributor probably, it would be dehydration. So I was actually reading a couple of stories a while back about sudden outbreaks of renal failure in workers on banana plantations in Panama. And I thought, well, that sounds odd. So I looked a little deeper into it and what was happening. You'd have these workers that would be on these banana plantations working in extreme heat and humidity and not drinking enough water. And they would develop these huge kidney stones, and they'd be so severe that it would cause kidney failure and they would end up dying from it. So I personally have had 2 huge kidney stones. They were so big, they basically never caused any problems. They're too big to move, and they're not going to break them up because that can be a shortly complicated procedure trying to pass, thousands of little shards when they're not causing pain. I tend to leave them alone. But it's because when I was in practice, I would go all day long without drinking water. So don't do as I do, but do as I say, drink your water. Wanted to mention urinary incontinence is something that men will only deal with typically if they've had a prostate surgery that damaged the nerves there, or unless they've got some other overriding neurologic disease such as Parkinson's or MS. But most women will actually deal with this. They've reported that numbers as high as 66% of women will have some degree of incontinence in their lifetime. And a lot of times they won't discuss it with their physician because they might find it a little bit embarrassing. But it's extremely common as you get older. It's extremely common after you've had children, especially if you had a vaginal delivery. And it's also more common if you gain weight as you get older. You may experience incontinence temporarily when you're late pregnant. Number one, you've got about 20 pounds or more of baby and fluid weight and uterine weight sitting on top of your bladder. But also the placenta, if it's not bad enough, it's sneaky enough to make an enzyme that is going to counteract or destroy the ADH that your body's making. So you basically have a temporary case of diabetes insipidus, and so you're peeing a lot. So you've got a combination of baby weight on your bladder and loss of ADH. Typically, this is something that will mostly go away after you've delivered your baby. Most women that I've known can remember if they had babies being about 9 months pregnant and peeing down their leg when they laugh or sneeze, something like that. But the process of simply carrying a baby for 9 months or 10 months, as we know it really happens, and the process, especially of vaginal delivery, causes so much damage to the muscles of the pelvic floor that quite often some degree of incontinence will be present after that experience. There are different types of incontinence. The one that's most common for women will be the stress incontinence, and again, I've already discussed the reasons why that might develop. This really has an effect on quality of life. I knew one woman that would talk about she loved to fox hunt, and so she would simply make sure she had nothing to drink for about 24 hours before she went out riding a horse, because she knew that the galloping of the horse would cause that relaxed bladder and urethral sphincter to cause bladder leakage, basically. Same thing as far as not being able to dance, run, etc. So it is a definite stressor on your lifestyle. And you'll see one of the reasons that people have the mesh implants. You may have seen the commercials advertising for lawyers that are willing to do the class action lawsuit for the damage that people have had for that mesh implant. But what they were trying to fix with the mesh was stress incontinence. So that is going to be finishing up this chapter, and we will move on into the reproductive system and development.